So the most common indication for nuclear cardiology is for diagnosis and prognosis of coronary artery disease. That will represent about 99% of what you do, you're going to encounter during the fellowship. And probably 80% of them will be someone you encounter in the emergency room with acute chest pain. You want to see if the patient has coronary disease or the chest pain is due to ischemia. And then the other indication that we use currently for in nuclear cardiology is for assessment viability. Obviously, now the MRI is probably the front line for this indication, but occasionally you have patients who cannot undergo MRI. So viability using thallium or technetium will be indicated. The third indication for nuclear cardiology, again, much more rare, is for assessment of LV function. Obviously, only if the echo, MRI cannot give you the diagnosis, you want to know the EF, usually in the setting of the need for defibrillator or IV therapy, IV pacer therapy. You can use MAGA or even regular myocardial perfusion SPECT can give you ejection fraction. And then for other indications such as PET, could be used for obviously myocardial perfusion, but also for viability with very good data. And one of the newer indications emerging is assessment of the endocarditis and infection in the cardiovascular location using FDG. So this is a summary slide. So I'm going to go in real quickly. Essentially, the essence of nuclear cardiology is you inject a radiotracer, you go to the heart, and then it emit photons, is captured by the detectors, and then you go to computer processing and then reconstruct the images of the heart to allow you to assess the structure. And the tracer we use is currently most commonly is technetium, either sestamivir, tetrafosfamate. As you can see, the relationship between tracer uptake and myocardial flow is not ideal. Water is obviously ideal, 1-to-1. So you can see that the tracer uptake doesn't represent exactly the myocardial flow uptake. That's a major drawback of nuclear cardiology. So, so besides perfusion, we also can assess the wall motion and ejection fraction and LV size. As you can see here, this is a typical display, the information that the nuclear cardiology study can show you. In the left-hand side, the perfusion. And the right-hand side can give you the polar map, give you the perfusion defect size in terms of percentage of the ventricle, LV function, wall motion. How is that important? Besides the perfusion, the functional information has significant prognostic implications and also can help you determine sometimes if the defect that you see is artifact or is true defect. And PET offers similar information with better spatial resolution. The only drawback here is with PET, currently you can only use vasodilated stress. So this is a Gated SPECT myocardial perfusion imaging, which I don't know why it's not playing. Okay, so give you the EF. Usually with SPECT, you underestimate the ejection fraction compared to MRI. So using Gated SPECT myocardial perfusion imaging, EF of 50% is considered normal. And as a matter of fact, just a historical perspective, nuclear technique, first application of nuclear techniques is actually for assessment of LV function and LV size here by Dr. Brownwell. It's back even before the echo was discovered. And again, this is important. Use a gated SPECT for assessment of wall motion. If you have, like this case, a fixed anterior defect and the wall motion is normal, it's a patient's fixed defect, it's supposed to be scar. So if you have myocardial infarction, the wall motion should not be normal. So if it's normal, most likely it's artifact. Like this case, most commonly seen in female patient. So not only Gated SPECT give you prognosis information because of EF and LV size, it helps you determine if the defect, as I mentioned earlier, is an artifact or is factual. Again, this is a slide showing the additive prognostic information of gated SPECT over perfusion imaging. So when do you use nuclear perfusion imaging instead of plain treadmill stress test for assessment of ischemia? Unlike in Europe or in Asia, I think here in this country, I think overwhelmingly majority of patients undergoing some type of stress test with imaging. But if you go by the board, this is true indication when you want to couple the stress test with the imaging. With chest pain of abnormal EKG, especially patient with ECG changes related to LVH, left bundle, and digoxin. Cannot exercise, obviously, or cannot exercise far enough. Has equivocal treadmill ECG stress test. And post-MI patient, obviously, you don't want to exercise to the maximal level, so you use most of the cases pharmacological imaging if the patient doesn't go revascularization. And patient with known ECG, coronary disease, bypass surgery, and stenting, nuclear perfusion imaging is much more sensitive than treadmill. Chest pain with moderate pretest likelihood for diagnosis purposes or prognosis purposes is indicated. I'm going to, for the sake of time, I'm going to go through this quickly. You know about. So just briefly, from practical standpoint, because besides ordering the stress test, I think when you go through the stress lab, you need to know what type of stress test to order, because oftentimes you're going to have internists or hospitalists ordering a test, surgeons ordering a test, and they're just going to just order a test, but you're going to be the one in the lab supervising the stress test, and you're going to decide what type of stress test is the best for the patient, okay? So stress test could be exercise or pharmacological. This is a type of the stressor that we use, okay? Dipyridamole as well. And it's how much increase in the coronary flow with each stress is depicted here. Exercise increase about 2-fold. Adenosine, Dipyridamole, or Adenosine increase about 4-fold, and dopamine a little bit less, okay? And this is how we detect perfusion defect. On the left-hand side, you have a vessel with 80% diameter stenosis. With the pharmacological vasodilation, it's going to increase about twice, okay? So he's actually still increasing blood flow to the stenotic area. That's very important for you to understand. That's why pharmacological stress is so safe most of the time. But in a normal vessel, it's going to increase by 4. And you can see the difference of the uptake. That's what we're going to determine the perfusion defect, okay? Obviously, in very rare cases of subtotal stenosis or total stenosis, total occlusion with collateral, you can sometimes with vasodilator produce coronary steal and produce ischemia. So in very severe stenosis or total occlusion, occasionally you can produce ischemia. Actually, you're going to have drop and the perfusion defect, perfusion in the area subtended by this severe disease, coronary arteries, but that's very rare. Okay, so exercise is the most preferred stressor when you have, if the patient can exercise, okay? And this is what you want to at least achieve 85% from maximum predicted heart rate and at least achieve 5 METs, okay? If you have a study has shown that if you exercise to a level less than 5 METs, the prognosis is, even if you have a normal stress test, the prognosis is not as benign as those patients who can exercise over 5 METs. And obviously exercise produce all sort of important information, ECG changes, heart rate, symptom, which is very important, functional capacity, heart rate recovery, PVCs, and obviously also produce better SPECT images because when you exercise, you have splenic constriction, so you have less tracer going to the liver and the guts, and so the image quality, the background noise is lower, so the image quality is better. The caveat is you need to be able to exercise to the amount that you want, and also medication can affect the diagnostic accuracy the testing, especially those anti-ischemic medications such as nitrate, calcium channel blocker, and beta blocker. Okay. However, in your clinic, I would say 80% of the patient that come in the first time for workup of coronary disease can exercise. But at the hospital, I would say, this 50% is probably underestimation. I would say 80 to 90% of patients that we do at the hospital as inpatient cannot exercise, okay? And so when do you consider pharmacological stress instead of exercise? So patient would not be able by visual, assessment. That's why you're a clinician. You can take a look at the patient, and at one time you can tell, okay, I think this patient can exercise. Due to cardiac conditions, orthopedic conditions, and deconditioning, or just doesn't feel like it, or if they are paced or have left bundle. So older patient, obese patient, and whatever reason, female patient is less likely to be able to undergo, I think most likely related to the age. One other indication for exercise for pharmacological stress rather than exercise is the patient has a left bundle pace rhythm because of this rhythm conduction related perfusion defect. You could have septal perfusion defect without having obstructive disease, okay? So it's true perfusion defect because of the microvascular changes, but not macrovascular changes. So you do a cardiac catheterization, or the epicardial vessel looks normal, but if you do PET, there's true decrease in the perfusion. So if your patient has left bundle or pace, pharmacological stress is a preferred method rather than exercise. Okay, I'm going to skip this. Contraindications, very important. Okay, if the patient is wheezing, you should not give the patient pharmacological stress. First degree AV block, over more than first degree AV block if the patient doesn't have a pacemaker. The patient is hypotensive, or patient use Dipyridamole usually for prevention of stroke. Relative contraindication if they have history of reactive airway disease, or heart rate less than 40, or have caffeine. Okay, so this is probably the most important slide. How much caffeine has in each major vendor, okay? And how is that important? There's a study done by Dr. Zogby, not Dr. Zogby here in Methodist, but in Alabama. So basically, they did a very smart, very slick study. They stressed the patient with known reversible defect in the SPECT, okay? So they repeat a stress test with caffeine and without caffeine. How much coffee they give? 8-ounce cup of coffee. So if the patient have 1 hour before and they repeat the stress test, the perfusion defect size is essentially the same. So overall, unless they have more than 8 ounces of coffee, just like 2 minutes ago, I mean, if they have a cup, like 6 o'clock in the morning, show in the lab at 8 o'clock, I mean, you can probably, a small cup, you can probably proceed with the study without sending the patient home. Or the option would be doing the resting portion first and then wait a couple hours to be safe. So how about asthma? Asthma or COPD. This is a newer regadenoson. It's a partial adenosine receptor agonist, much more selective to the coronary arteries. So basically, excuse me, patient have mild or moderate COPD or asthma, regadenoson is safe, okay? So this is just the data with patient if FEV1 changes is really about the same. It's also safe in post-heart transplant patient. So essentially, we don't do dobutamine anymore, okay? Because with this new regadenoson, who has been proven to be safe in moderate COPD or asthma patient heart transplant patient. So dobutamine, essentially, we only do it patient who has wheezing. They cannot have echo done. And I don't remember when was the last time we did a dobutamine nuclear. Okay, the last thing is very important. Although we talk about, pharmacological stress is as good as exercise for diagnosis and prognosis information, but you're going to have a better picture if your patient can walk at the same time. So you put the patient in a treadmill, low speed, you're going to have better pictures, and the patient going to have less side effects. So if possible, you should always couple low-level exercise with your pharmacological stress, okay? Now it's pretty much standard in most of the lab. Okay, so kind of a summary, how do you choose the proper stress? Exercise is the preferred method of stress if the patient can do it, except if they have left bundle or they're being paced. Pharmacological stress is currently recommended if there is no contraindication, okay? And it's about the only method of stress for PET, even for, I think, for MRI and CT perfusion. Tubular stress, only the patient with advanced AV block or patient with active wheezing, but in those cases, tubular could be used. Okay, but the choice is obviously depends on how comfortable you are with using all this technology.